Okay, Dr. Levine, thank you for being here. You have actually been requested. There's a couple people said you're their doctor, and I know that you are a wealth of knowledge. I'd love for you to introduce yourself and tell us a little bit about who you are, how you got here.
Sure. So, Rachel, thank you for having me. My name is Dr. Brian Levine. I am a double board certified reproductive endocrinology and infertility specialist. I am the founding partner and practice director here at CCRM New York, which is a fertility clinic in Midtown Manhattan. We're part of an integrated network of clinics across America with 17 locations today and more opening up. And we do comprehensive reproductive medicine. We help the patients who have trouble getting pregnant, the patients who have trouble staying pregnant, and those who want to protect and preserve their fertility. I have a keen interest in third-party reproduction. Not only do I do a lot of surrogacy services within my practice itself, I also run a venture-backed startup called Nodal, which is the leading online surrogacy platform in America, helping to make gestational surrogacy more affordable and more accessible. So I'm happy to be here tonight and to answer any and all of your questions.
Amazing. I met you a few years ago when you just started Nodal. It's crazy to see how far it's come. I've even done an evaluation now from an intended parent who brought a gestational carrier, and she was amazing. Okay, questions. Do you prefer natural cycles if someone menstruates very regularly or still medicated?
Wow, that's a loaded question. So let's go backwards to go forward. Natural cycle frozen embryo transfers, which is what you're referring to, are popular for a couple of reasons. One, having a natural cycle frozen embryo transfer effectively means we let the patient ovulate on their own. And then a couple days after they ovulate, we put back an embryo that's a couple days old. You get to reduce the amount of medications, reduce the amount of interventions, get to eliminate those really painful shots in the butt called progesterone and oil. And so from a patient perspective, people really love the experience. In fact, there's a really powerful study that demonstrated that this methodology may be associated with better outcomes, including but not limited to lower rates of preterm delivery, lower rates of preeclampsia or errors of implantation, and lower risk in general to the pregnancy being a high-risk pregnancy. But here's the problem. One size doesn't fit all. And patients come in asking about their natural cycle frozen embryo transfer sometimes before they even have embryos. And what I counsel patients with is that although there's been innumerable studies that have shown equivalence between a programmed embryo transfer, which means you take about 17 days of medication, give or take, even though there's been equivalence between programmed cycles and natural cycles, never has superiority been proven. In fact, many of the studies that have been done in such a scientific manner that they show what's called non-inferiority, which is two really big words, effectively just saying it's not worse than the standard of care. Now, there's a problem with natural cycles. Humans are not lab rats, and they don't always ovulate at the same time. So you might want your doctor to do your transfer. You might be a patient of my practice where 25% of my patients live from outside of driving distance of my office, where you're flying in for your transfer, flying in from abroad, flying in even from Florida or California or wherever else you're from. And there's a lot of variability with natural cycle frozen embryo transfers. So what I tell patients all the time is if you menstruate regularly, which means you ovulate regularly, mazel tov. You got the first check towards the box. And if this is something you want to work towards with your doctor, definitely bring it up. But just understand that we have an entire armamentarium of different protocols that we can use to help patients get pregnant based upon the right information for what they need.
At what point do you recommend a patient move forward from using their own eggs to consider donor eggs?
Great question. And I hope the questions get easier because you're giving me like all these heavy questions.
Yes.
And it's fine. So the problem with donor egg, to be blunt, is that for many people, it's not the story they imagined. But here's the deal. You're a therapist. You get it. And patients get it when they talk about someone else. When it comes to themselves, for some reason, everything changes. When I ask a patient, why are you here today? Which is the second question I ask every patient. The first question I ask everyone is, how'd you hear about us? Because I'm always curious. Who's gossiping? Who's spilling the tea? What they hear? But when I ask patients the second question, which is, why are you here today? Almost universally, unless they're here for egg freezing, I or we want to have a baby. They don't come in saying, I want a baby with my own genetic material. They don't come in saying, I want a baby with my partner's genetic material. They don't come in saying, I want a donor egg baby, unless it's a gay male couple, right? For example, they know they don't have eggs. They come in saying they want a baby. And we try our best to help them achieve that reproductive outcome that they desire, which is having a baby. But sometimes, either due to egg quality or egg quantity, and yes, those both go in line when it comes to age, but sometimes they can be divergent as well, right? You can be really young with bad eggs or really old with a lot of eggs. Neither one of those patients have a very good outcome. But sometimes you get to the point of diminishing returns, where you recognize that the utility of someone trying with their own eggs is exposing them to risk that is greater than the chances of success. Now, there's something really important in healthcare. There's two words that you need to know about. The first word is medical futility. And a lot of people don't really like this word, which is where we say that the efforts are futile. I could throw a ton of medicine at someone, they're still going to make good eggs. I could throw a ton of medicine at someone, they're just not going to make embryos. So sometimes that's when you decide to move on to donor egg. But there's also the word of closure. Even though you might know in your heart of hearts that this patient is 99.9% not going to get an embryo, let alone a baby, you let them try. Not because you're a slimy doctor, not because you're a slimy business person where you're trying to just make more money on cycles. It's because the patient has to actually physically, emotionally, spiritually understand they have done everything possible to try it the traditional way. And now they need the help of science to help them get to this next step. So it's a very loaded question and it's a very loaded conversation. And in fact, this afternoon, I spoke with a patient exactly about donor egg. And this is how the conversation went. I'm not telling you no with your own eggs, but I'm asking you to consider opening another door or opportunity with donor eggs. And I told her, we're not going to discuss this today. We're not, but we're going to discuss this tomorrow. And you're going to take what I told you and probably interpret about 15% of what we said, and 85% went over your head. And that's fine. That's my expectation. And if you heard more than that, amazing. But tomorrow, you're going to wake up, and you're either going to love me or hate me or be annoyed that we had this conversation, but we're going to address it head on. And we're going to talk about donor egg, and we're not going to make you jump to it right away. We're going to make a 3 to 4 month timeline where you get comfortable with this concept and we get comfortable with the process for you. And that's how I do. That's how I deal with it.
I love that response of grasping the mental part of it. Yeah. Okay. Next question, maybe a little bit easy. Which supplements actually help women with PCOS who are trying to conceive and which are just hype?
Oh, Jesus. Just love the doozies. So
These are all expert women that have been
It's
through this
okay.
for a while.
I'm going to flip a question to you for a second. What is the most powerful medication that you take multiple times a day?
Water.
Close. After water, food. Whoever said that, thank you. That's correct. So patients come in asking about supplements all the time. And I remind them to say the word out loud. Supplementation, supplements. By definition, that means you are adding to something. So we focus so much on the add-ons that sometimes we forget about the building block. And what I tell people is you can't worry about the shutters until you have the foundation of the house, right? You need a basement, foundation, build the structure, build the house, paint the house, then we could talk shutters. I view supplements kind of like shutters sometimes, which is they're the dressing. If you have a bad habit like smoking or drinking, that's going to be more powerful than any supplement or any dietary restriction that you put in your PCOS. So stop your toxic habit. If you're not exercising or you're sedentary, said otherwise, let's get you in the right frame of mind. Let's get you healthy. Let's get you moving, things like that. If you're eating an inflammatory diet, you're infertile and you're pissed. And so you already finished The Hunting Wives or whatever that show was on Netflix. So now, you're watching even worse Netflix and doom scrolling on Instagram and eating ice cream every night. Let's work on that because you need to be eating for preparing. And what I remind people is that fertility journeys are marathons. They're not sprints. You need to prepare your body of mind, body, and soul. You need to think about the thing that you put into your mouth multiple times a day, which is the food that you're consuming. I'm not telling you to give up sugar. I'm not telling you to give up the stuff that tastes good because dopamine hits are important. But what I am telling you to do is to think about what you're eating and to really get yourself onto a Mediterranean diet if you have PCOS. Now, once you're in that right frame of mind and you're hydrated and you're educated and you're nutritionally complete, what else can we do? We know that myo-inositol is probably the best supplement to take for PCOS because myo-inositol is effectively poor man's metformin, which helps reduce insulin resistance within the body. But we also know that potent anti-inflammatory agents work really well too. Things like CoQ10, acai berry, things like that. We also know that NAD is actually probably proving to be quite powerful. So all of a sudden, I start telling you about all these supplements, or people are like, oh my gosh, what do I have to take? What do I do? And I tell them, don't worry. There is a company that's put it together, and I will fully disclose that I am one of the advisors to this company. But I do like the parallel prenatal vitamins quite a bit because that's a little sachet of multiple vitamins of multiple types that actually help people. And they have a PCOS package for it, which I helped design it. I have no financial gain, by the way, but I helped them design what to put in there. And what I tell people all the time is that supplements are supplementation to your lifestyle and diet. They're not going to get you pregnant and they ain't going to fix your smoking. If you're doing everything else, they can be the difference between a baby and a bad cycle. So I don't poo them, but it has to be part of a greater therapeutic regimen.
Clearly, my head does not go to food. The first two things I thought of was water and then exercise, and I was like, I need to like look into my own psyche here.
The example I'll give you is you can be skinny fat by eating power bars all day long. And power bars are highly inflammatory, super high in sugar because they're meant for running to burn it off. They're not nutritional supplementation. Or sometimes people go onto these like fad diets. If your body's running from a lion, it's not going to let itself get pregnant.
Yeah. Okay. This one's not going to be easy, I don't think, but here we go. I've had 2 miscarriages and previously tested positive for endometrial inflammation. I've since moved to gestational carrier. She has had 1 failed transfer and 1 chemical pregnancy. I still have several PGT-A embryos, but I'm torn. Do I keep trying with the same gestational carrier, or is it likely that the issue is with my eggs? How would you approach this?
Okay. Are these just going to keep getting harder and harder?
Yeah, maybe possible.
I think that's the theme tonight.
Someone asked what a chemical pregnancy is.
Got it. What is a chemical pregnancy? Chemical pregnancy is effectively a swing and a miss. So imagine if any of you guys are into baseball, you swung at bat and maybe you touched it, maybe you fouled it out, but it didn't go where you want to go. That's a chemical pregnancy. A true negative pregnancy is the real swing and a miss, where you didn't even get close and the beta was 0. But in a foul ball where you made contact and you got a hit, same concept for a biochemical. The beta HCG went up from implantation, but it did not persist as a successful pregnancy. Non-successful persistence of a pregnancy can be due to a whole bunch of things, including, but not limited to, the obvious one, the embryo, which the woman alluded to in the question. Embryo quality directly impacted with outcomes. However, not all embryos are made equal. If you have a hatching embryo or a hatched embryo, those are more likely to have biochemicals than an unhatched. If the gestational carrier happened to get sick during that transfer period, maybe she got a cold because there's a cold flu going all around America right now. Maybe she got norovirus. Maybe she has some systemic illness. There's a lot of mitigating factors that can happen for a biochemical pregnancy. But I would say that a biochemical pregnancy, like touching the baseball and fouling out, is reassuring. The embryo was put in the right place, and she probably has the glue for an embryo to stick. And maybe it just wasn't the right time. So if I was the doctor on that case, I would help my patient pick herself back up off the ground because I'm sure she's devastated. Because anytime you're working with a surrogate, it's emotionally expensive, it's physically expensive, it's financially expensive. But I would tell her, go right back at it and do another transfer. And if you want support for where my argument comes from, there's a wonderful paper written by Richard Scott, who is the one who used to be the lead of RMA of New Jersey, which is a really big practice. And he demonstrated that even after negative transfers or biochemical transfers, patients are best served by doing successive transfers before changing the transfer protocol or doing advanced diagnostic therapies. Said otherwise, keep going. Don't give up. Don't try to change everything. Go for it.
Okay. Next. How does endometriosis affect IVF outcomes, and what are your go-to strategies for managing?
Great. So the number one way to manage endometriosis is to know what you're dealing with. I cannot tell you how many times I want to bang my head against the wall when a patient comes in here and tells me I'm an endo patient. And I ask them, how do you know this? And she says, my fertility doctor did an ultrasound. She showed me. It's great. Where's your MRI? Wait, what? Why MRI? I was like, that's the best modality for imaging of your body. They've ever done one. Okay, do you have a tissue diagnosis? Did you have surgery? No. So then why do you have endo? I had a test that showed it, or I had an ultrasound that showed it. So I always tell people, get the proper workup first. Sometimes, though, when you know you have the diagnosis of endometriosis, you then have to think about what makes it good or bad or otherwise. So what can make endometriosis worse is inflammatory diets, inflammatory foods. We know that unhealthy habits, smoking, things like that can make it worse. We also know that endometriosis is an incredibly progressive disease. It never gets better. It only gets worse. However, there's gradations of how fast it happens. We also know that when you're pregnant, endometriosis does not persist. It actually goes almost dormant because there's something that happens in the body with the immune modulation of HCG, which is the pregnancy hormone, that helps keep endometriosis at bay. Strategies that I use: appropriate diagnosis and understanding of the severity of disease, number one. Number two, if there's visible disease and the antral follicle count in AMH is good, do you send her for surgery to go get it resected? Because we know that egg quality will go up when it gets pulled out. Third, do we think that we would actually do more harm with surgery than good? So let's go get embryos, but then let's either put her into a medically induced menopause called Depo-Lupron or Orlissa, or let's get her surgically managed before transfer. And those are my strategies.
Okay. For patients freezing eggs with large fibroids, 10 centimeters plus, what concerns come up and how do you decide whether to remove them first?
Fantastic question, and an easy one. So this is where people get hurt by big fertility practices. True story. These are the patients where they get to retrieval and the doctor says they couldn't get in. They couldn't get the eggs. This is why having a doctor who's directly involved with your care with every step of your journey is so important. Because classically, the doctor who does your initial office visit is going to make an assessment. And hopefully your doctor does your assessment. Because we all know in the ultrasound exactly where the needle will come out. So people need to get an ultrasound done by their doctor and an assessment of if their ovaries are accessible. If the ovaries are not accessible, then go get your myomectomy. If the ovaries are accessible, do your egg freezing first, then get your myomectomy.
Okay. Here's a question on Nodal. How does Nodal find and vet gestational carriers? Are medical records reviewed before matching? And what's the cost structure for intended parents?
Great. So I tell everyone to go to nodal.com and you can read about all of it there. But the short answer, because I want to be conscious of the time, is that we are one of the few agencies in America that vet all of our surrogates with a high throughput medical record review before they ever even get presented to an intended parent. So we actually do all the vetting, all the screening first, and we use a really high-tech, high-throughput modality where we can actually check pretty quickly if patients are being truthful and how we actually go through all of their results. We then put together a profile, we get psychological screening, and then we send them off to the clinic. And we also know the clinics so well now in America because we've already done over 150 matches. So we know which surrogates will fly and won't fly at certain places. The cost structure, you can go read online, but Nodal's figured out how to crack the code on keeping surrogacy to be inexpensive. And we average somewhere around $125,000 to $150,000 per journey, which is well below the industry standard today of $200,000 to $250,000.
Okay. How do you handle a patient with high AMH and lots of follicles who still ends up with poor quality embryos? What do you change?
So I address their PCOS that their doctor hasn't talked to them about. I get them onto a good diet, good regimen, and I dial down the drugs. Less is more.
Okay. Do you believe in these?
So the ERA, or the endometrial receptivity assay, is a challenging question. The person who invented this, Antonio Pellissier, wrote a beautiful paper with Carlos Simon, his partner at EV in Europe, talking about the mea culpa and their regret for creating the ERA. The problem is that the ERA led to a lot of people doing diagnostics before therapeutics, but not every person has a problem with the implantation window. And what they found was that changing the implantation window did improve outcomes. So I don't like the ERA. However, I do like endometrial testing for the right patient, for the right indication.
How do you feel about immunology testing?
So I respect the field of reproductive immunology. I recognize that there are a subset of patients that have challenges with implantation and persistence of a pregnancy that are likely immune modulated. With that said, my fund of knowledge is not in immune biology, and so that's why I typically like to phone a friend with someone who is a reproductive immunologist. I do hope that the Society for Reproductive Endocrinology and Fertility, the SREI, really petitions the American Board of OBGYN to include this as part of the educational programming of how they're training reproductive endocrinologists in America, because patients are asking for it and it's real.
A gestational carrier is matched and cleared, but then develops thyroid antibodies before transfer. Would you still proceed?
If her thyroid status is normal and we can prove that it's normal for 3 months, I would continue. I think we had a couple questions in the chat. If you want to
Are you open to it?
Yeah, I have a few minutes. Go ahead.
Okay, great. As a backup to the natural cycle question, if you are doing IVF for PGT and not because of fertility issues, why would an REI not want to do a natural or modified natural cycle other than convenience?
Because you may not know that you actually already have infertility. And you might think you came in for a PGT-M problem, which is a diagnosis of a genetic condition. But in reality, you might have an implantation problem. So it might be to help improve your odds of success. Maybe you had a thin lining throughout your entire cycle of stimulation. So there's multitude of reasons why someone might still recommend a program cycle.
Another question. My doctor did not have a reason why my AMH dropped 3 points in 1 year. Curious if there is any reason.
Absolutely, there's a reason. And the question is, was it your blood either time? It's been said in Latin, to err is human, which means we all make mistakes. And fertility clinics are busy. And I cannot tell you how many times you see a patient who first had an AMH of 4.5 and then had an AMH of 1.5, and they're like, what the heck happened here? And in reality, maybe the wrong vial of blood was labeled with the wrong person's sticker because it was a busy clinic that day.
Wow.
That happens all the time. Maybe the machine was off. Maybe the standard curve on the machine was off. But here's where it gets better. Anyone having their AMH tested should also be having a transvaginal ultrasound done at that time. They should have an assessment of their ovarian reserve. If you have 24 follicles, then your AMH is probably 4.5. If you have 5 follicles, 10 follicles, your AMH is probably 0.5.
She actually did follow up and said my first retrievals on Sunday and only 2 to 3 follicles.
There you go. So either wrong blood, or she could have been taking a supplement like biotin, which could have led to an abnormal spurious result.
Next question. What are your thoughts on the Provera protocol? I have heard it has been shown to have promising results and require many less injections than the traditional protocols.
It's cool. It's very European. And what I mean by that is the Europeans are all about low interventions. So they limit blood work, they limit ultrasounds, they limit stuff. And so what we've actually been able to demonstrate in the literature, and it mostly came out of the research about luteal starts, which means starting someone on IVF in the second half of their cycle after you've ovulated. What we've seen pretty cool is that if you give someone Provera, which is a progesterone, during the cycle, you can prevent them from having a spontaneous ovulation and limit the need for ganirelotrusetrotide. But you're only removing one shot. And if you're already taking shots, what's the difference? Side effects. People don't talk about this one. Taking progesterone can make you hungry, make you sleepy, make you puffy, make you bloated, make you unhappy, make you constipated. I don't know anyone who likes being puffy, bloated, sleepy, constipated. Maybe you do. So just be aware that there are some side effects to it.
Can you please speak to the process of mitochondria replacement, which has been proven successful in the UK? Does this offer real promise for older women?
Mitochondrial replacement therapy is illegal in the United States because you're not allowed to have a 3-parent child, which means basically taking the nucleus of an older woman and putting it into the cellular structure of a younger woman. So you're basically using the machinery of the egg from a young woman and the brains from an older woman. This therapy is illegal. The only places you can do it are the UK and Mexico. And for those individuals who are interested in it, you can go read about it online. There is a bunch of people who started a clinic in Chicago. You can go look it up, where actually they're doing this in Eastern Europe, and you can go fly to Eastern Europe to get it done. But here's my advice for everyone about who is chasing mitochondrial replacement therapy. If it was so good, the FDA would have a better look at it. And what we don't know how to counsel patients is about what happens when you have mitochondria from one parent, which has its own genome, and you have a nucleus from another parent. So basically you're inheriting genes from different places and what that interplay does later in life. It's just not ready for prime time. Maybe one day.
I have 2 questions of my own, and then we will let you go. These are more fun questions. If you had to swap careers for a month and you already were amazing at it, what would you choose?
Airline pilot.
Dr. Park said the same thing. Oh, no, she said flight attendant.
I'd be an airline pilot. Do you want to know why?
Yeah, go, please, of course.
Being a fertility doctor is like being a pilot. It's a lot of checklists, checks and balances. It's a lot of risk. It's a lot of fun, and you get to go fast. And the one thing I don't get to do as a doctor, is because I'm only taking care of patients, is travel the world. So if I could do it for a month, I'd go around the world, and then I'd come back and take care of my patients.
Okay. And second question, do you go to bed with your email inbox at 0, or are you one of those people with thousands of unread messages in your icon?
So I'm schizophrenic about this. My work email is always at 0 before I go to bed. And my personal email has 14,000 in my Gmail.
I love that. Someone had also asked a question that I had forgotten to ask, so I won't say it before the end, but she said she's had a bad experience with IVF fertility doctors, and she wanted to know what sets you apart. That's a good opportunity for you to answer that.
So many people are smarter than me. Our field is super small. There's only 45 of us who come out of training a year in America. People don't realize how small our field is. And I'm definitely not the top of the class. There's so many of my colleagues who I think are so much smarter than I am, and they publish and they write and they do really thoughtful things. But what I think I do every day when I walk in here is I try to treat patients the way I want my own wife to be treated. And I try to do when I go home is to go home to my family, and I'm blessed to have 2 healthy little girls, is I try to leave here at least hoping that I made someone's day better than when it started. So I try, and I think I'm a trier. And I'm a doer, and I'm a talker. And so I'm not for everyone. I'm not perfect. I'm also not a robot. But what I try to do is to talk to patients to understand the sensitivity of what we're dealing with every day, to understand that it's an imperfect science, but we're doing the best that we can. And we're just trying to get someone there. And so I think what sets me apart is I believe in partnership, right? Patients forget this. A patient's success in my clinic is my success. I am completely judged on outcomes, right? That's how government ranks me. That's how private equity companies rank me. That's how it all works. It's all about outcomes. But there's a lot of way to get to outcomes. And you get to outcomes, I think, by having people feel comfortable with the decisions that were made along the way. And so I like to have partnership. I like to have buy-in. I like to give patients agency. But more importantly is I like to just be honest, because I think that the worst thing out there is that there are a bunch of mediocre fertility doctors. And let me tell you the truth, those mediocre fertility doctors are the richest doctors in our field, because a mediocre fertility doctor has engaged their patients, engendered trust. The customer acquisition costs are zero for the subsequent cycles, and they just keep cycling and cycling. And I would never want that to happen to my own wife. So instead, what I do is I talk to patients the way that I want my own wife talked to, and I hope I give them the honest answer. And then I rinse and repeat. I come back the next day with a smile on my face, knowing that for a lot of patients, they're white-knuckled and terrified to be here. And I try to at least have them have an experience where hopefully I make them laugh a little bit. For those of you who are old enough, I love the movie Patch Adams. It's one of my favorite movies with Robin Williams. And I try to use a little levity, and I try to make it a little bit better and a little bit sweeter for what could be a very sour experience. Here's a little secret I'll tell you. Doctors don't give their emails out. Doctors don't give their cell phone numbers out. I put it at the bottom of all my emails. But here's what I've learned after doing this now for 13 years. Patients don't abuse communication tools. Patients feel comfort in knowing that they have a lifeline. So if I can give patients a little lifeline, electronic communication, and they know that I'm human, I'm not perfect, so I won't always respond right away, but I will respond, then it's a great deal. And it's a great partnership.
I love that. I do the same. And people say, oh, you'll give your number out and stuff and people can contact you in between sessions. I'm like, yeah. And most don't, because I feel like they just want to know you're there.
And those who do, it's because they have to.
Yeah, exactly.
Great. And I'd much rather they email me than Google, because it will take more time for me to de-Google them than to answer their question.
Is it now ChatGPT?
Oh, I hate ChatGPT. Although, fun fact, a patient showed this to me, which is the creepiest. I'll leave you on a high note. The creepiest thing a patient did, I don't even know if you use like a verb yet, but a patient put me into ChatGPT and said, who's the top fertility doctor and what makes them the best? And like literally, and goes, and what makes Brian Levine better than the rest? And it was like so creepy.
They knew so much, right?
But ChatGPT knows everything. Like they find patient reviews, they find articles that I've written, they found talks that I've given, like source all this crap. And I was like, wow, this is so scary. But ChatGPT, I tell everyone, is a consumer level tool. You can't go to Target to get treated for infertility. That's where you find consumer level stuff. So just remember, you're putting your trust into a trained professional. So come to us and we'll talk to you. And it doesn't have to be me. I have 3 amazing female partners. I'm not for everyone, but I have 3 great partners, and we will get you seen in a timely fashion. And we will get you help in a timely fashion.
Amazing. I don't know why anyone wouldn't want to go at this point.
Well,
thank you so much for your time.